Good afternoon, everyone, and welcome to this symposium. With us today, two friends and excellent professionals, Jorge Andrés Chavarría from Costa Rica, San Vicente de Paul Hospital, and also a professor of the University of Costa Rica, and Natalia Pinilla from the McMaster University. And we'll begin with this symposium on algorithms in OCT-Guided Percutaneous Coronary Interventions, MLD Max. Before we get started, let me say a few things. Jorge and Natalia, we would like, with Carolina Perovicini, to thank all of the doctors and members of that have been struggling in this during this pandemic. A lot of coronary units have been shut down, and now our intensive care units and a lot of our colleagues have become therapists to be able to fight against this terrible pandemics we've had for a year and a half now. Not only medical doctors, paramedics, everybody that is involved in this health sector, from managers to maintenance people that have supported or made so much effort to fight against this pandemic, to help to support the community. So this is in honor of those people and the industry that has enabled us. Even though we don't have person-to-person meetings, we can actually continue with our specialization and continuing medical education. Thank you. Let's begin with the presentation. Jorge, Natalia. Alejandra, thank you very much for such a beautiful introduction during these hard times and hard times for everyone, professionally speaking, family wise. We have learned to recognize a lot of values that we did not notice. But for example, these virtual meetings before were not that nice. We didn't want to join to speak on the phone. And now we have the opportunity to spend some time together and enjoy. So your words have been really kind. Thank you very much for such a warm message. And, we can be here together despite being far away. This virtual, this technology, and of course, thanks to ABBOTT and SOLACI for giving us this forum to discuss image. Jorge and I are really excited because we'll be showing two beautiful cases in the MAD Max context to put together cardiac image and CT images to support complex interventionism. So this is the message we want to convey. The dynamics, basically we'll discuss the origins of MLD, and then we'll show you the algorithm in two cases so that it's more interactive. Alejandro, if you have any questions or comments, just you can interrupt us at any time. So first, let us share with you the origin of MLD Max. And well, they have the intravascular imaging with the highest resolution of the market. And how can we have doctors use these images? There are many barriers, financial issues, time issues, because some people say that it's very complex, it takes more time, and that there's a lot of information that they don't know how to use it, so it makes the procedures more complex. So ABBOTT um, decided to come up with an algorithm and put together some guidelines so that interventionists could actually follow them, and whether that could actually help case flow in the cath lab, so that OCT, instead of making the case more complex, would actually facilitate it. So this is we put this together into an algorithm that basically the different steps in different American centers with over 50 operators that used OCT in interventionism. Uh, and, and so the question was whether Imogen actually changed their workflow. So experts decided on what was the most important thing of this procedure and how imaging could actually help procedure planning. And Alejandro, you may remember at the beginning, imaging was taken at the end of the case when there was a complication or the stent did not look nice. So people used imaging in those circumstances, and this led us to think that imaging is not so important, but we could use it at all times. So a lot of many engineers with cardiologists, interventionists performed an angiography, what stand, what diameter, what size, how you're going to put it, and whether a balloon is going to be used. And then an OCT was taken, and then back to the interventionist, what kind of stand would be selected, long, short. So they realized after analyzing all of these over 600 cases that interventionists changed their plan in 88% of the cases. So this message, I mean, the people using OCT in interventionism could change their decision in almost 100% of the cases. When they analyze data, they realize why they changed their decisions. And the most important thing was the kind of plaque and the plaque preparation. So when they analyzed these data, they saw that in 51% of the cases, interventionists had to change their decision because they saw calcium in the OCT. They could not see that on the angiography. So they said that calcium actually makes complex interventions. And out of these 51%, half of the cases, they had to use balloons. Uh, in a quarter of those cases, scoring balloons, and the rest uh, with other balloons. Another important thing is that I mean, if you do it wrong, you do it wrong because you're placing a small stent. But if you just use angiography, we'll see that the same percentage, I mean, playing a larger stent or a smaller stent, um, based on what we really need. And after imaging, you can see your job can become so much more accurate. And all of this data actually showed in real life that these things actually take place, that angiography has a lot of limitations. This is an interesting chart or graph that so when you do OCT before placing the stand and before the procedure preparation, you perform dilation in 85% of the lesions before post PCI OCT. So the message is that by having an algorithm, interventionists change their decisions because they see things they don't see on the angiography. They can plan procedure and optimize the procedure and decide on the length, the stent size that is required. They do this more in a more optimal way. So this is a workflow that can be used in the cath lab that gives us a sort of a perfect recipe to follow to use an algorithm that helps us in diagnosis and planning of the procedures. And when this was launched into the market, It was just like having a recipe available, which are the most perfect parts in order to have optimal interventionism. And it is funny because a lot of interventionists think, okay, what are we going to do if we are removing all of the fun of the intervention? We'll not be able to think or discuss. We're all aware of this, that if you have five colleagues observing in angiography, the five of them will place a stent in a different way, a different size, different length. Some use balloon, others don't. So some do kiss and balloon as others not. So this was just an attempt to sort of standardize these concepts and come up with a perfect recipe for intervention. So MLD Max will be showing in the cases is to basically organize our minds, because when we perform an OCT, there's so much information you can't even put it together in the procedure. So this helps us focus on what really matters, to focus on morphology, which I think is the most important thing, aspect of the algorithm, and then decide on the stand, the size, the length, and decide the optimization that you believe the stand will be need based on the image and the balloons, the number of stands, whether it's a bifurcation strategy, you can plan it, and your procedure. And in the OCT, that it's performed later, is to actually assess that the stand is in the right position and well expanded. So their slices and very clear algorithms are what really matters. What the most important thing, since we don't want to speak a lot, I mean, we want to show you the cases. I like to focus on the image preparation. The most important thing, or the plaque preparation. If we have superficial calcium, we don't have much time. I mean, if you use a compliant or non-compliant balloon, you will achieve good expansion. The issue is when you have this calcium on the right that is concentric, very thick. This is where you have to plan your procedure better, because this is the type of calcium that will prevent a perfect expansion. In morphology, the lipid plaque, you can put a stent in the fibrous cap. You need to make some modifications with a compliant or not compliant balloon, but the thick calcium and superficial calcium, this is the worst calcium we need to focus on. And in both cases, we'll show today, there's calcium to be able to enjoy those images. This is just a quick overview on the algorithm and how we're going to use it. In the case you define the length, you're sure that you're not putting the stent in the iliac. You pick the diameter based on the external measurements, and if you don't find the external elastic layers, you can use a size on the lumen. We're going to over the lumen, because this is not real life. You will not see 360 degrees of the layer. And regarding the optimization, there are very clear tools in OCT to define and focus on the fact of not having a distal dissection that is deep. And then there are some other very nice tools in the OCT console to show the apposition. There's an apposition bar and other percentages that are automatically analyzed. They show that, I mean, how well expanded is the stand distally and proximally. So in the cases, we will have a look at these algorithms in a you see how a procedure that was thought to be more complicated, then it becomes simple. Now, Jorge, I would like you to show you the first case, which is our favorite, because it is actually having all of the images together that help us simplify this case.
Can you hear me? Yes, we can hear you fine. Alejandro, thank you very much. I echo Natalia's words for that introduction, and definitely I'd like to thank you for the opportunity to share with you during the SOLACI Symposium. Thanks, ABBOTT, also for allowing us to still enjoy this passion of sharing images and procedures supported by intravascular imaging. As Natalia said, this is one of our favorite cases, especially because we are involving more and more the analysis of different images and the correlation of these approaches to make the best decision with our patients in complex osteal LAD PCI. Especially I think about the younger interventionists because we don't have as much experience as our professors, and these approaches that are systematic allow us to offer the patient a procedure that is safer and most of all to give better outcomes in the long term. This is a real life case. It's very controversial, as Natalia said. More often than not, we have to adapt the algorithm to make the best decision in order to prevent any complication for the patient. But we also see the manipulation of the different images for these processes can help us make a decision within the discussion of the heart teams. So this is a male, 77 years old, hypertension, dyslipidemia, and peripheral artery disease. He was referred by his clinic, his family doctor, and we met him in the settings of CCS class 2-3 angina. And when we saw the historical information of his angina, we were able to see that he had a severe osteal LAD disease, and with high Agustin calcium score in all the coronary arch. After we diagnosed him with this angiography, his main physician referred him to us, and that confirmed the angiography showed and confirmed what we saw. In this image, with an angiography image without contrast, we see that it's a highly calcified vessel. We see calcium on both walls of the artery. And in this image of the head, we see that the LAD in its mid-third, maybe it's not very clear in your screens, but there is a myocardiac bridge that was confirmed by the CT scan, by the coronary angiotac. Taking into account this, the ostium in LAD, and that it was not been a candidate for, we're gonna have to work on the main. The patient was evaluated in our team, among the people in our team, and we said, okay, do we call a surgeon for MICS, CABG, or CABG, or do we proceed with PCI, considering that we're going to deal with a severe calcified morphology, and we were going to have to go into the main with different strategies to change that plaque. If we analyze the tomography in detail, we see that, yes, we have the proximal calcification in the LAD, but the lesion that we had in this case, it had certain characteristics in the CT scan with a low attenuation, not calcified in the site of biggest stenosis, which is at ostium level. There is another detail. We're going to see how this new approach allows us to plan a better strategy. For instance, in this case, even to save radiation or contrast, because these virtual 3D models allow us to even analyze the best projections, so that when we are inside the cath lab, we can go directly and guide ourselves to do less projections and less use of contrast. So here you can see pretty well how this proximal stenosis is not highly calcified, and we can see also the segments that are intramyocardiac. So we this intramyocardial course, we were thinking, okay, is a bypass the solution? Is it going to be very complex to perform? Well, we decided that the strategy with CTA and OCT, focusing on the main and through an analysis of these calcified lesions, whether we had to change this plaque. So the comparison between CT scan and OCT, this eccentric lesion with an excellent correlation with the CT scan image. We see an absence of calcium or a calcium plaque. Here we have an image that has high density of the signal in the most superficial areas closer to the lumen, and how there is an attenuation in the farther parts of from the lumen. And considering this analysis, both imaging strategies, we decided to do the strategy by intracoronary artery, a strategy that we're going to show you now directly from the console. The great thing about that case, at the beginning it looked like a very complex lesion with a calcium score above 2000, which is a nightmare for us in the cath lab. And as you showed in the ostium of the LAD, there was more than 40. So when we think about interventionalist, we thought about ablation and that it was going to be a complex procedure until we went back to the CT scan. It was not that severe, and it was not the most calcified as what you're showing here. But that lesion had pretty much distal calcium, but the lesion was eccentric, and the calcium was not giving us luminal extension. Right. And we want to show that when we are planning an approach for a bifurcation in the main, it's important to do the baseline pullbacks for the arteries. This is in the LAD. There is a correlation, very nice correlation with the images that we saw in the CT scan. The longitudinal plane of these calcified plaques, 160 degrees without an important stenosis. But when we go towards the area that is of our interest, we can show this plaque. I don't know, Natalia, if you want to describe what you see. Yes. What we see in the CT scan is that calcium nodule that is protruding and that is smaller than a quadrant, and the other segments that are at 35, it's mostly a soft plaque, mostly liquid and fibrous plaque, which is not calcium, very complex calcium to modify through an intervention. That's what we thought before we had this image. So what the algorithm does in the LAD, the morphology of this plaque, help us make this decision. We don't need to modify or to use a rotablator or any excessive dilation. In terms of the length, we decided to cover the main with the goal of making sure that we're going to cover the plaque completely. And at distal level, one of the main messages to take home, we want to show you how when we're dealing with this type of calcium plaques, we can also make a decision about our distal landing in a safe way. So here, I'm going to zoom in and I'm going to activate the light surrounding. So what would be your decision in terms of the sizing of your stent in your case? Well, the size, we cannot see the external elastic sheath as in real life we cannot see, but if the person is living with this, we use the lumen and you go to the next one above. One more. So the mid diameter is 3.82. So the recommendation is that if you use the lumen of the stent, one stent higher than that, and if you use the external elastic uh, sheath, then it's three smaller. So maybe a a stand of four is appropriate. So remember that we have this application within the software where we can activate this profile, this lumen profile, that allows us to find our proximal and distal landing, and it gives us the length of the stent we're going to use. So a diameter of 4 millimeters in a stent with a length of 20 millimeters is a very good option. Jorge, can you show the proximal optimization for the length? Because that's why we decided to cover the main in order to have a sure main, a sure length. So that's another important detail. We also have the tool here to measure the length, and we need to take into account all the tools that we have in our lab. For instance, if the shortest balloon is 8, we need at least to have proximal coverage where we're going to do the pod of 8 millimeters. So here, the main length is 5.7 millimeters. So these 2 millimeters can be outside when we have post dilation. Any other comment, Natalia, that you'd like to make? No. I think you have to show something important. When you are going to do intervene in a bifurcation to see the lateral branch, which is the circumflex, which was a huge branch, a very important vessel, and what happens in the ostium, and to predict if you think that CTA ostium is going to be affected. And in this case, the ostium, the area of the ostium, was pretty well preserved. The area was above 6, if I remember correctly. There was calcium, and the truth is, at the end of the day, calcium protects to prevent the misplacement. As you can see, the morphology 7 and 8, you see that there is a calcified nodule that is going into the lumen, and then at 9 o'clock you see the LAD. So with this calcium that is there, it's going to kind of protect when you place a stent. So with that image, you rest assured that the ostium of the circumflex is not going to be modified. If you have the area there, what is it? In this case, we have an area of 7.24, which is completely perfect, and that's important before we plan the procedure. Correct. And remember, you can use the cross-sectional view and to turn it around, and at the same time to analyze the longitudinal model to define the area of interest that you want to analyze. In this case, if you don't know whether this is LAD, you can go frame by frame so that you have that information very clearly.
Now we'll show you what we decided to do. The lesion to be treated is the LAD proximally, and the provisional strategy was selected based on our image, basal image analysis. The summary of the procedure, you can see we implanted a DES 4/24 in the LAD towards the left main with poured a POT of 5/8, I'm sorry, and we also, this is also based on the algorithm. We performed a kissing balloon 2.5 to the circumflex and 4.8 in the LAD, also based on the sizing, the initial sizing. And since we were dealing with a calcium nodule, we decided to perform another OCT in order to define whether we had obtained a good expansion or not. In this case, we saw that the expansion was not acceptable, so we continue with a more aggressive post-dilation with a double layer balloon and a second kissing balloon with a non-compliance balloon 2.5, and the repot again 5.0, and finally the OCT approach, which we'll show you now. I believe you should show the image because if he decided to perform a very aggressive post-dilation with a double layer balloon, what you saw it in the LAD, the Austral LAD, I believe that in the fourth, this is, you see the under expansion. So when we are approaching the result of the intervention, we have the max algorithm, as Natalia explained. M is searching for dissection at the edge level and dissections that could lead to a faster scarring procedure or an early artery occlusion. And A is about position and X is expansion. So the software allows us to, as you can see here, if we activate the light profile, we can select the stent edge, the proximal edge, and to visualize this position indicator that very quickly can tell us about the elements we could have in terms of a non-acceptable position. When we're dealing with calcium, we could have certain segments that are not well positioned, but if the condition is appropriate, then it can be left as an adequate result. So that distally, there's no dissection. So the 4.0 sizing on this calcified plaque was appropriate. However, when we look at expansion, we see we have 59% of expansion following the taper algorithm in order to approach the expansion of the stent. It is exactly in the segment we had identified, a calcified nodule. And thanks to this image, we decided for a more aggressive post-dilation with a double layer balloon. How did you come up with the decision of 4.0 with a double layer balloon up to 40 atmospheres, 36 atmospheres? Well, the taper mode, that ostium of the LAD, the lumen was almost 4.5. So when we use a double layer balloon, we want to use a value that is below the lumen of the vessel, because those they are quite aggressive, 40 in terms of dilation. This is this is for the insufflation, that it would be 40 atmospheres, 40. As Jorge is showing, the measurement is 4.35, 4.49. So 4 at high pressure, we thought it would be enough for post-dilation in this segment. And then, based on the fact, based on kissing, otherwise, there would be a lot of expansion, and we didn't want the ostium, the symphylax, to be affected. And the luminal area measurement, we want to increase 0.25. We want to use this luminal measurements. We don't have a clear evidence on where the external membrane is. And after this, we performed a new final assessment in order to follow the algorithm, and this is what we were going to see here. So the first part of the acronym is searching for distal dissections, and as we can see over here, there is no dissection. We're close to diagonal bifurcation, and we're dealing with a very short segment of non-apposition, but it is good. The stent is properly expanded. So from 59% expansion, we moved to 82% expansion, and the minimal luminal area is no longer located in the LED, but it's distally on the calcified plaque, and we don't want to actually fracture it. The the short axis image, once we rotate it, we see the software allows us to perform another assessment. How open is the strut after the kissing, and we can see that this can be manipulated in different ways in order to define the location of the guide wire, and whether, I mean, if there's a lot of protruding material at the bifurcation level, you can rotate the short axis. You can see we can get these kinds of images. You can zoom in and zoom them out to assess, I mean, to come up with a very good result after kissing and at the end of the procedure. In this particular case, the two main objectives of the algorithms are met. The most important thing is expansion. Expansion leads to better outcomes, long-term outcomes, and this expansion, this non-apposition in the distal segment in heavily calcified plaque for us is acceptable. Natalia, Alejandro, did you like the case? I loved it. I loved it.
It is so great, such a complex case at the beginning. The OCT, to what we thought it was going to be complicated, it simplified it, and you can rest assured that you had a main approach that is perfect and you cannot worry. I love that image, Jorge, when we get used to the angiography and we see that ostium and the circumflex that way. Wow, we found the ostium of the circumflex, and we can see the OCT of the circumflex, and the area of the ostium of the circumflex was not affected, and we didn't need to do an interventionism. So this gives you just a 2D image, and you can exaggerate or underestimate the findings because the image is very poor. So in this procedure, something important about the efficiency using OCT is that a procedure like this, after 6 hours of interventionism, people say, okay, OCT is very costly, the catheter is very expensive, and our managers say it's not justifiable. But at the end of the day, if you can send a patient that has a main intervention who goes home after 6 hours without the need of hospitalization, I think that justifies the value of the catheter, the cost of the catheter. And something else, when the nurses start coming, the patients feels a chest pain, and we call the main physician the next day, and you say, I don't care. That is expanded, no dissections. I don't repeat angiography. The chest pain is not important. And that confidence that you have in the procedure with the transvascular image is not given by anything else. Well, Natalia and Jorge, to use the algorithm of MLD Max, how do you select the patients? Without a doubt, in Latin America, it is complex because of what you said, Nati. Using images in all the patients. How do you select the patients to use the algorithm? And what patients, apart from these, you discriminate against in order to do a CT scan? That is a very good question, Alejandro, because in Canada, the health system is a public system, like in many Latin American countries. Here, we don't use OCT. Yesterday, in Greg Stone's Gary Means talk, it's not like in New York and Manhattan, they use imaging in 100% of the cases. In Canada, that's not the reality. We use images in the cases that require so and that are most benefited. So, for instance, in a stent failure, we always, whether it's at 3, 4 o'clock in the morning, in a busy day. That case has OCT, and that simplifies it quite a lot. Yesterday I was on call, and nurses love that they do an OCT, and because there is a vulnerable plaque. This is atherosclerosis inside the stent, 324. The efficiency of ending the case and to plan your procedure, optimal procedure, it gets clear. In those cases, there is not a doubt. The other cases that we do are these bifurcations where there is complex interventions, calcified plaques. Those cases are done with OCT. And another important case are the acute coronary syndromes where the culprit lesion is not done. Young people, for instance, who have coronary lesions that do not look like a dissection, but you need to be sure that that has arteriosclerosis, that has an LAD lesion, whether it's a Takotsubo or it's a vulnerable plaque. In those cases, when the injury or the lesion is ambiguous, we do it. You would not believe the number of eroded plaques that appear as a blurry image on the angiography, but that there is something important. Those are the cases that I would say that are always done. And what we're trying to do, if we have to do ablation, retrotrixia, to do these with this technology, because the risk of those technologies is that they are too powerful. You have a 40 atmosphere OP of the balloons. You have to say that you have to make sure that the balloon size is correct and that you're not going to have complications when using those devices. The other important point is that this technology is evolving very, very fast, and the data shows that we do safer procedures with better prognosis in the long term for patients. One thing that we see now all the time is that in patients with some level of kidney insufficiency, these procedures were using less contrast, and at the same time we are protecting the staff more because we're using less angiographic projections, and to define ambiguous lesions, instead of doing 3 or 5 projections and using different types of injections with only 2 projections, octagonal with a registry, we have all the information, and for instance we can plan all the procedure. If we apply, for instance, MLD max, we are sure that the balloon we're using is going to have a deep dissection. We don't have to do continuous tests to see if the artery has been perforated or if at distal level it was dissected. And at the 4 different points with the angiography, we do 2 final injections and then shots, and then I think this is going to evolve a lot more with the low contrast, and also with iBoost, that we should use contrast, but also with OCT, where we need to plan initially with the contrast. Alejandro, let me tell you a story. I'm so fast using OCT that one day I was on call at 2 o'clock and I had 3 patients on the hall. So how am I going to do these 3 procedures? And I said, okay, take the OCT catheters, in, out, stent, done. And I was the most efficient one doing those cardiac arrests, and they said, wow, you were much faster using OCT. So I think it's important to become familiar with the measures. If you do it and you don't know where they are, it's complicated, and that's a very important role to promote education and to explain how to do it easier. Then it's all simplified. I wanted to show you this other case. This is a 74-year-old man with all the risk factors, and he had a complete heart block with a permanent pacemaker, and the patient had a class 3 angina, progressive. They did an MPI that showed that he had LV dilation post-stress. Something important about this person, he said that he had a 25-year-old girlfriend, And he said, my girlfriend is 25, so doctor, if you find something, try to fix it, because he wanted to be good healthy. He is a patient that I really appreciate a lot. I love him and laugh a lot with him. When we do the angiography, there is something important about this right main, because I couldn't inject contrast. There was no way to hook the right ostium, even though I tried with an L. I couldn't enter the contrast, and it's like a blurry image in the ostium, but I couldn't understand why. And now in the image I will show you why. This lesion that is kind of blurry, every time I see a blurry lesion in the right main, I say it's calcium until otherwise proven, and he has a diffuse disease in the midsection of the artery. The left system had a main that was distal main disease, and this circumflex was pretty ill in 3 different segments, and the LAD, of course, was not less. I mean, it had, in the video we cannot see it very well, but it had pretty, we had a lot of lesions in the ostial and medium sections. So here, this is the guy, my patient. All of those attending this webinar, this guy is 74 with a nuclear test of high risk. He has a 3-vessel disease, is diabetic. So heart team round quickly says, okay, you have to debate it, at least in the heart team round. And diabetes was another important factor. When we did a heart team round, we had to use CABG, and he said, I'm not going to do it. How long will I take to recover? I go to the Caribbean with my girlfriend. I don't want to go with that scar. I heard that Dr. Pinilla has some stents with an imaging technique. The patients know everything. So I want Dr. Pinilla to fix me. So that's the story of my patient. And from that procedure, he became my patient forever. So I still hear his stories about him and the girlfriend. The intervention on the right that I wanted to show you is pretty nice, because I realized that I couldn't inject the contrast in the same way with the catheter that I placed. And when I did the one on the right, I realized that what there was right in the right ostium, as I said, every time there is an image that is blurry in the right coronary artery, it's always calcium. It's not a thrombosis, it's just calcium. So for sure, I was trying to put the diagnostic catheter. It hooked here in this calcium thrombosis, and the great thing about the angiography is that this is the problem with these patients with multivessel disease. If you're going to compete with surgery, it has to be within a perfect intervention. Otherwise, the surgeons will make fun of you, because they will say, okay, your stents didn't work, you didn't do a good job, like in the bypass surgery. This was a quite diffuse disease. I want to show an error that they make, all of them who make OCT. They're in the catheter, in cath lab, they look at the screen, they display. This is the most boring thing that you can do with OCT, seeing these images run at this speed. In this sense, you lose time. You play the play button. We never use it. Another important thing is that this image, length image, we never use it. All the procedures are based on this upper, the lumen profile area. And another important thing is for interventions, it's really helpful after you choose a distal area where you are going to place your stent, you can use the length, this length tool to decide the stent. In this case, we had to place 2 stents because of this diffuse disease, and quickly analyze the type of plaque in this patient. Most of the distal plaque was lipidic. It had microvessels. It had calcium that was mostly in the proximal side, but as you see here, this is a plaque that is completely lipidic at 360 degrees. As you can see, some macrophages, it was fibrous, and in the proximal segment we see calcium, but calcium was not as complex, and the truth is that the most complex plaque was the ostium plaque with that calcified nodule. So at this point, we decided to do predilation with a non-compliant balloon at the proximal level, and we had to put both stents pretty far apart. But then, in the results, when we see this artery, the before and after, and once again, you remember that you used an algorithm to place the stent in a perfect position in this right coronary artery, then you rest assured that your intervention was successful. Something important to say, and this is a tip: when you put two stents, different calibers, the tools are not perfectly designed for these long stents. So when you place two stents, try to analyze each segment separately, because when you take everything to the very beginning, software will not put everything in perspective, and at the end of the day it's going to dissect in severe infra expansions, which is not the case. So in this image, it's important, because of the tools of the OCT, that the stent is in apposition. This is the apposition bar. And then as operators, we need to learn to trust in these tools with eyes closed. We blindly trust them, because if you have a pulp that is pretty clear, the tools can be used with high trust. They are telling you exactly what it is.
And here in the expansion, these are the distal segments first and then the proximal segment, because the software mixes it up when it's too long. And you can also use this other tool, stent expansion tool, that divides the stent into two segments, and then you can move this around in any direction. But this tool will always split the stent into two, and if you're not happy with the segment, you can move it upwards or downwards, whatever direction you want. I will just not spend any more time on the left, because I'm more interested in the main left and the LDA. This was carried out, performed in 2 times, because the patient had kidney failure. So there were 2 procedures, and the OCT tools in the lumen profile, you have these pink dots, which are the bifurcations. And as you know, this angiography, you know exactly the branches that you're interested in, which are these 2 diagonal branches. You can also see them on the image, longitudinal image. The most important diagonals are these 2, which are over here with these yellow dots, and this helps you. And as I knew that this diagonal was too large, the first stent, I wanted to place it after the diagonal, so that stents are not overlap right at the bifurcation. And then we decided the stent of the LAD. To decide on the segment, the stent that I wanted to show you this plaque, and the majority of the in the MD max is you can see the ostium in the ALD. This is a plaque which was so vulnerable. They had eroded or ruptured in the past, and that I mean, they had a scar tissue, and this is the and over here, this is the scarring, and it probably was a thrombosis, that, and all of this was the plaque that is in the LAD ostially, and this is the plaque that extended to the left main. And over here you can see the left main. This is the transition from the circumflex. You can see how this plaque, and in the left main you can see that it is below 6. So after this imaging, I knew that the stand I wanted to place would be the LAD. I mean, it had to be the LAD due to this, this plaque. Let me show you the circumflex that had plaque, but it was not as severe. So with this, I decided that the circumflex ostium was not bad enough in order to cover it with a stent. And let me show you here in the transition, the left main. This is the transition in the ostium of the circumflex, and it was much nicer than the LAD ostium with a lot of differences. To simplify the procedure, this ostium, this circumflex ostium, the area was above 6. I decided to place a stent from here to the proximal segment. As you can see on the angiography, the circumflex was quite diseased, and after placing two overlap stents, and this is the result. The ostium was not covered because the area was above 6, and this is, you can see in the record, the result. But the Max algorithm showed us the stent was perfectly placed. This is the apposition tool. The stent is white, completely white, but when we shifted to expansion, this stent is not perfectly expanded, and we had to optimize it. Here you can see how the software tells us exactly which segment it is. Here we are looking at the expansion and indicating that this distal segment is yellow red, which means that it's below 80%. And if you want to optimize it, it is exactly in that segment and no other segment. So this is the way how the software simplifies these procedures in this patient. Optimization was performed exactly in this segment. The rest of the segment was very well positioned and expanded. In the post PCI of the LID, let me show you, the disease was quite diffuse. This is how we simplify the procedure, which was quite complex, but we were able, the main three vessels were left open. And you can see here how in the distal segment there's no dissection, and the stent is well positioned. There are some red segments, and I will just click on the red segment, and I am sure, for example, this is a pollution. This is blood contamination, and there's another red point over here. This is also contaminated blood. So this stent is perfectly. It's a perfect deposition. With long stents, you should move on. You should look at segments separately. So here the stent and the expansion is above 80%, so the result is quite good. So this is the way, basically, Alejandro. So if you use these tools, then procedures become more simple compared with, I'm sorry about, I'm really excited about this. So, very beautiful demonstration, but we are out of time. And I would like just to make a few comments. First, your 74-year patient with this coronary disease and this bi-chamber pacemaker, I would recommend to, to to spend more time with a girlfriend. This will decrease the incidence of sudden death for sure. One question just to wrap up, and you talked about the algorithm to discharge patients, early discharge. Just a few seconds, if you could tell us about the percentage of early and late. How does the algorithm benefit? 100%. Everybody goes home. Nobody stays in the hospital. Patients coming from their homes. These complex interventions, we use rotablation, CTOs, bifurcations. Everybody goes home that very same day. After 6-8 hours, 100% goes home. Patients using algorithms that are admitted due to acute coronary syndrome, because they stay, but interventionists go home 100% in these patients, these complex spaces. So we have to end the symposium. Thank you to ABBOTT for the organization, Jorge, Natalia, Jorge Chavarría, Natalia Pinilla. Thank you very much from Max Baxter University in Ontario. Thank you very much. We'll see you soon. Thank you.